Hello, and welcome to this video on the concept of dentally referred pain. I am Tanya Chamberlain from the Division of Anatomy at the University of Leeds, and in this video we will be looking at some of the red herrings you may see in practice. Before we explore today's learning objectives, let's recap some of the pathways associated with the trigeminal nerve and therefore sensory information from the face. On this image we are looking at a coronal section of the brain. Firstly, let's remove the cerebellum and help tidy this image up. It would be really helpful if we could throw in some of the nuclei we are going to find relevant today. Let's recap the structure of the brain. First, we have the cerebrum. The cerebrum is surrounded by the cortex, which is where we'll find the sensory path terminates and the motor pathways start. We also have the diencephalon. This is where we can locate the thalamus, which, remember, acts like a switchboard or relay station for directing messages to the appropriate area of cortex. We have the midbrain, the pons, and the medulla, which collectively are termed the brainstem. We should quickly take the time to recap some of the nuclei which we'll be looking at more closely. First up is the thalamus. Strictly speaking, the thalami aren't nuclei, but instead are a collection of 60 different nuclei. However, for the purposes of this video, we will consider the thalamus as a whole single place of synapse, as when we consider each different nuclei within the thalamus, it gets extremely complicated, and it is hugely unnecessary for what you need to understand. Here we can see the first of the 4 trigeminal nuclei. This is the mesencephalic nucleus. The chief nucleus you may see too referred as the main or principal nucleus, the motor nucleus, which is responsible for sending motor fibres to the muscles of mastication, and finally the spinal nucleus of the trigeminal nerve, which we will focus on in this video. This sketch is a very simplified perspective of the sensory nuclei, as in reality they merge together down the length of the brainstem, but this would have made what we are going to talk about today very hard to follow. For the purposes of today, we will imagine that they are very distinct regions. We should review the trigeminal sensory pathways. We can see that the 3 branches of the sensory division of the trigeminal nerve converge at the trigeminal ganglion. This is where they house their sensory cell bodies. The root of the trigeminal nerve enters the pons and is able to project their first order neuron onto the appropriate trigeminal sensory nuclei. In the event that proprioceptors receive stimulus, these first-order neurons project to the mesencephalic nucleus. In the event that fine touch receptors are stimulated, these first-order neurons are projected to the chief nucleus. And in the event that nociceptors or pain and temperature neurons are stimulated, the first-order neurons are projected to the spinal nucleus. All of these first-order neurons project onto their ipsilateral nuclei. Once these first-order neurons are at their appropriate nuclei, they synapse with a second-order neuron, which crosses the midline and enters the trigeminothalamic tract to arrive at the thalamus. From here, it synapses with the third-order neuron and is projected to the somatosensory region of the cortex, the postcentral gyrus. Now we've caught up, let's focus on the learning objectives for this video. After this video and any necessary further study, you should be able to outline the neuroanatomical mechanism in which pain affects sleep-wake cycles and hyperarousal that manifests in patient symptoms. Describe the mechanism by which the CNS tries to mitigate pain. Outline the pathways of referred pain within the head and neck. Explain how sinus infections, ear infections, and cardiac disorders can present as craniofacial pain. Explain how the symptoms of trigeminal neuralgia in line with current research. And let's address some of the effects of pain from the neuroanatomical perspective. The first thing we should look at are the effects of pain on the sleep-wake cycle. Patients with pain, particularly chronic pain, often mention that the pain feels worse at night, and as a result of this, pain prevents them from sleeping. On this image, we can see that the nuclei have been labelled. These are called the reticular formation, and they play an important role in the sleep-wake cycle. As we can see, the first-order neurons are travelling from the trigeminal ganglion and synapse with the second-order neuron at the spinal nucleus of the trigeminal nerve. On here we could see that the first order neuron synapses at the nucleus, but what we can also see happens is a second order neuron that synapses at the reticular formation. As we have said, the reticular formation plays an important role in the sleep-wake cycle. Sending out pain transmissions to this area can reduce sleep or sleep quality, promoting sleep deprivation and disturbed sleep in patients experiencing pain. There is another pathway that the second order neurons can often take too, and this is one which is going to apply to the emotional aspect of pain. This involves a region called the limbic system, or more specifically, the amygdala. The second order neurons can also synapse at the amygdala. The amygdala and the limbic system are very ancient parts of the brain. What we mean by that is that they are shared by many of our close and distant relatives. They work to make us fearful and prevent us from getting into situations that may cause us harm. If we have a past experience of pain from an event, that memory is stored in the limbic system, and it reminds us that undertaking a particular action that has caused us pain suggests that we should probably avoid a repeat performance in the future. If we think about this from a dental perspective, a cavity in a patient's tooth may make them avoid chewing on one side of their mouth because it hurts. The patient then seeks treatment, and the cavity issue is resolved immediately. It can be a few days or even weeks before the patient returns to chewing food on the affected side. This is because they are still battling with their limbic system, as the memory of pain prevents them from chewing on the affected tooth. This also explains why some patients may develop dental phobias. One bad or painful experience at the dentist can dissuade patients from seeking treatment in the future. So this is something to bear in mind when treating your patients. Something else to think about is the physical effects of pain on a patient. Some patients report their heart beating faster, some report sweating. In people and animals, we see that the pain causes an increase in pulse and blood pressure and respiratory rates. In some patients, we can even see increased perspiration. This is because pain can trigger a systemic effect on the sympathetic nervous system. Second order neurons are also able to synapse at something called the hypothalamus. The hypothalamus is a part of the brain that is responsible for the endocrine system. It monitors and changes hormones within the body. When stimulated by second order neurons in the pain pathway, the hypothalamus secretes hormones which instruct the adrenal glands to secrete adrenaline. The secretion of adrenaline promotes a faster heartbeat, faster respiratory rate, and prepares us for fight or flight. Pain is useful to us because it keeps us safe, but the body itself doesn't particularly like pain as it can prevent us from undertaking safe and necessary tasks. Pain is only beneficial short term where there is a risk of damage. But when the damage is resolved, or when we need to be able to function whilst in pain, how does the brain dampen down pain transmission so we can go about our daily business? Well, this is one of the pathways in which can be undertaken. Here we can see that fibres of the second order neuron pathway are able to synapse with a really cool region of the brain called the periaqueductal grey matter. Also, let's remove the second order neurons travelling to the reticular formation because that is unnecessary for this part. And let's add in some of the neurons from the Raphe nuclei. Neurons from the Raphe nuclei synapse onto an interneuron which releases serotonin as a neurotransmitter. This acts to inhibit second order neurons from transmitting pain to the thalamus. In effect, what we have done is we have turned off the transmission of pain. Serotonin is strongly associated with mood too. This is why we see a lot of pharmaceuticals that are prescribed for mood disorders like depression and anxiety are also found to be useful in the treatment of chronic pain. That was quite a lot of information to take in, so let's take a look at where we are on our learning objective list for today. So this learning objective has been addressed by looking at the previous section, but now we need to have a look at how dentally referred pain is generated. One of the leading theories, and thankfully the only one we are going to address today, is something called the convergence projection theory. And in summary, what this theory encompasses is the idea that many first-order neurons synapse onto a single second-order neuron. So let's take a look at an example. The image on the left is a very simplified trigeminal nerve, and on the right we have blown up version of the trigeminal ganglion and the medulla, showing the two portions of the spinal nuclei of the trigeminal nerve. Again, this is very simplified because I just want to be able to see an overview of the process. This nerve is the inferior alveolar nerve, and in this case we are going to see branches of the inferior alveolar nerve coming from the mandibular central incisors. The inferior alveolar nerve travels within the mandible and towards the trigeminal ganglion where its sensory cell body sits, and it passes through to the spinal nucleus where it synapses onto a second order neuron. On the left we can also see the nerve to the mylohyoid muscle. This innervates the anterior belly of the digastric, so it has a muscular and also a sensory component. But whilst we are only interested in this sensory function today, the sensory fibres travel up to the mandibular branch of the trigeminal nerve through the ganglion where its sensory cell body sits, and also synapses the second order neuron in the spinal nucleus. Here we can see that two first order neurons are synapsing onto the same second order neuron, which is how we perceive pain from one area when a noxious substance is actually stimulating first order neurons in a different area. In this particular example, damage in the submental region of the face can be referred to the mandibular incisors, which is where we would expect a patient would visit their dentist rather than their general practitioner. Let's see if we can make sense of this using a very simplified metaphor. Imagine that you are this person, and you are stood at a platform at a train station. Let's think imaginatively that that train station is called the Cortex station, and it is located in a busy city centre. Now imagine that you are waiting the arrival of a train. You can't see where the train is coming from, and as this station is very busy, you know that multiple trains can arrive at the Cortex station. Now, imagine two trains further down the line. One is coming from the mandibular central incisor station, and one is coming from the submental station. Each of these trains leave their station and merge onto their own track. This is like the first order neuron. Somewhere along the journey, these trains need to merge onto a single line in order to end up at the same station. This is because there isn't room near the city for hundreds of different lines to reach the station on separate tracks. So they reach a switch point, which we will refer to as the spinal nucleus of the trigeminal nerve. From here, they need to travel to the cortex. Let's call this the second order neuron. The problem is that when you are stood at the cortex, we can't tell where that train has arrived from. This is a very simplified explanation of pain. The cortex is where the pain is perceived, but some confusion about where that pain originated from because we have first order neurons synapsing onto a single second order neuron. The cortex isn't entirely sure where it came from, but nevertheless can still detect the pain. So in the body, referred pain largely exists in the same dermatome, and in the face, referred pain will largely be interpreted by the same branch of the trigeminal nerve. However, this isn't always the case, and there are some limitations to this theory because not all referred pain follows the dermatome rule. Let's have a look at some red herrings that may encourage the patient to visit the dentist rather than their doctor. Here are 4 cases. Pause the video and read each of these cases, and then we will go through what might be happening. So in order to know why we might be experiencing these red herrings, we need to know a little bit more about the spinal nucleus. Remember, this is a very simplified diagram. The spinal nucleus also receives first order neurons from other sensory cranial nerves too. It receives neurons from the facial nerve, the glossopharyngeal nerve, and the cardiac branch of the vagus nerve, and some of these will synapse onto the same second order neuron that the mandibular branch of the trigeminal nerve also synapses onto as well. So we can get referred pain from the glossopharyngeal, the vagus and the facial being perceived in some of the regions in which the mandibular branch of the trigeminal nerve innervates. So let's go back to our cases. Let's see this in practice. The first case is this 30-year-old patient who presents to the dentist with pain in bilateral molars. Her examination was fairly normal except for mild teeth grinding, which is evident. She says that the pain sometimes moves into her temporal region, and over-the-counter medications and non-steroidal anti-inflammatory drugs help to mitigate the pain. What is going on here? Well, the patient is grinding her teeth. Think about the muscles that allow for teeth grinding. We're thinking about the masseter. The masseter is innervated by the mandibular branch of the trigeminal. Think about the action of grinding your teeth. Not only are you increasing wear and tear of the teeth, but also on the TMJ. What branch of the trigeminal nerve innervates the TMJ? The auriculotemporal from the mandibular branch. She also complains of pain in her temporal region. What branch innervates the temporalis muscle? Once again, the mandibular nerve. Remember that the temporalis muscle is a muscle of mastication and so is innervated by the mandibular branch. Pain is being perceived in the teeth. What innervates the mandibular molars? The inferior dental branches from the alveolar nerve, also from the mandibular branch of the trigeminal. All of these branches synapse at the spinal nucleus of the trigeminal nerve, but they may be synapsing onto the same second-order neuron, and therefore the cortex is unable to determine where the noxious substance is coming from. Case 2 is our 25-year-old patient with left maxillary premolar pain. They are normally well but have recently had a terrible cold. The examination of the teeth and mucosa are unremarkable, meaning that there was nothing obviously wrong with the teeth or mouth. The first thing that should shout out is that this patient has had a cold or upper respiratory tract infection. From our anatomy, we know that the relationship between the teeth and the upper respiratory tract are very close. With a cold, patients often experience inflamed sinuses. The maxillary sinuses are fairly prone to inflammation and infection. The mucosa of the sinuses are innervated by the middle superior alveolar nerve, which we also know innervates the maxillary premolars. This means that pain from the maxillary sinuses can be perceived as coming from the teeth on the same side. So you'd expect that referred pain from the left maxillary sinus would be seen in the left axillary premolars. You would not expect that this pain would be contralaterally presented. Case 3 was a young patient with right-sided jaw pain. He is normally well, but he's known to have repeated middle ear infections. He's recently had an ear infection which was treated with medication and seems to have resolved. Let's have a look at some of his history. First up, this patient has ear infections, also known as otis media. The middle ear is a passageway for the chorda tympani, part of the facial nerve. On this image, we are looking into the middle ear, and we can see the close relationship of the branch of the facial nerve called the chorda tympani. We know that we have the facial nerve branch synapsing onto the spinal nucleus of the trigeminal nerve. Therefore, we know that the cortex is going to struggle to determine the origin of the noxious substance, and pain from the ear is being perceived in the TMJ, which is innervated by the auriculotemporal branch of the mandibular nerve. Our final case is very interesting, but you'll see that it makes perfect sense when you interpret the anatomy. This 64-year-old male presents with dull jaw pain but has no signs of TMJ dysfunction. What we do know about this patient is that he has CHD and hypertension. So first, let's consider his past medical history. He also has the presence of high blood pressure. This puts the patient at risk for ischemia of the heart muscle or even an infarction of the heart muscle. These could be commonly known as angina or myocardial infarction. The myocardium or heart muscle is innervated by the cardiac branch of the vagus nerve. We also know that some of these cardiac branches will synapse onto the same second-order neuron of the mandibular branch. Therefore, it might be that this patient is having cardiac events, but the cortex is unable to determine where the pain had come from. Pain is being perceived in the jaw rather than in the heart. So those cases were interesting, and now let's move forward and have a look at trigeminal neuralgia, which is another type of referred pain, but with a different mechanism to the ones we've looked at in the spinal nucleus. Trigeminal neuralgia is defined as a chronic pain condition characterised by recurrent brief episodes of electric shock-like pains which affect the trigeminal nerve. This supplies the forehead, cheek and lower jaw. According to this international classification of headache disorders, it is normally unilateral and has characteristic paroxysmal facial pain. What that means is pain can be intermittent, but when a flare-up starts, it comes in rhythmic bursts for a short period of time before it disappears again. The pain associated with trigeminal neuralgia cannot be overstated. In fact, this disease is often, perhaps insensitively nicknamed the suicide disease, due to the high rates of suicides associated with this illness. The pathophysiology of disease is thought to be demyelination of the trigeminal root shortly after it exits the pons. Demyelination can arise from demyelination diseases such as MS, or it can arise from vascular compression by nearby vessels such as the superior cerebellar artery, the anterior inferior cerebellar artery, the great protorsal vein, or the vertebral veins. It is mostly found in biological females above the age of 50. Current proposed theories of trigeminal neuralgia are vascular compression by the trigeminal nerve, which damages the nerve and allows for ephaptic transmission. What this means is that the nerve can misfire on its own, or fibres from neighbouring demyelinated nerves can pass on their transmission. What happens is that gentle stimulus can be exaggerated by multiple transmissions that are passed on to the second order neuron, making it seem as though the stimulus was much greater than it actually was. And this pain is perceived as pulsatile and sudden. Because this is most commonly found in older patients, it is suggested that there is likely atherosclerotic changes within the vasculature of the brain and increase the vasculature compression of the trigeminal nerve. On this image, we are able to see some of the anatomy we think contributes to trigeminal neuralgia. Here we can see the trigeminal nerve, the ganglion, and the three branches arising from the trigeminal ganglion. If we look at the root of the trigeminal nerve, we can see there are several nearby vessels, some of which we have already mentioned. First, we have the superior cerebellar artery and the superior protorsal vein. In the case of trigeminal neuralgia, there are multiple surgical techniques that help relieve the paroxysmal pain. One of these options is to move the vessel associated with compression of the trigeminal nerve and place a spongy implant between the vessel and the nerve to prevent recompression. It is thought over time that the trigeminal nerve can remyelinate and the pain will cease. It won't work for other reasons of demyelination, but there have been improvements in pharmaceutical medication to help relieve some of the symptoms. And this brings us to the end of the video. You should now be able to fulfill these learning objectives. Outline the pathways in which pain affects sleep-wake cycles and hyperarousal that manifest in patient symptoms. Describe the mechanism by which the CNS tries to mitigate pain. Outline the pathways of referred pain within the head and neck. Explain how sinus infections, ear infections, and cardiac disorders can present as craniofacial pain. And finally, explain how the symptoms of trigeminal neuralgia can arise in line with current research.